Proceeding to our next group of talks, I would request our chairpersons, Dr. Mahesh Navda, Associate Professor, Department of Obstetrics and Gynecology, Father Mullers, and Dr. Prashant Mappa, Consultant Endocrinologist at Kannur. We request our chairpersons to grace the stage and chair the session. I would now like to call upon our esteemed speaker, Dr. Kaushik Biswas, who will take us on the screening for diabetes and early pregnancy.
First of all, I like to thank for inviting me as a chairperson, us both. And we have Dr. Kaushik Biswas for the first session, as of course it's a HbA1c level in early pregnancy. He's a consultant, presently senior consultant in adult and pediatric endocrinologist in Manipal, and he has published more than 50 articles in various journals, and his area of interest is mainly on thyroid, obesity and pituitary. Over to Dr. Kaushik.
EndoDiabCon 2025, thanks to Dr. H.K. Ganesh sir. I will be discussing about screening for hyperglycemia in early pregnancy. So, we know that the GDM or hyperglycemia in pregnancy is defined as any form of or any degree of glucose intolerance with onset or first recognition during pregnancy. According to 2019 data, we know that around 16% of live births were complicated by presence of some form of pregnancy associated hyperglycemia. According to 2024 data, we can say that 1 out of 7 in the world and 1 out of 5 in India, in Asian Indian perspective, are complicated by hyperglycemia in pregnancy, and Indian women especially are in very high risk to develop 11-fold risk of development of gestational diabetes mellitus during pregnancy. We know that hyperglycemia during pregnancy or GDM is associated with both short-term as well as long-term complications, both to the mother and fetus. Short-term complications, we know that preeclampsia or pregnancy-related hypertensive disorders, obstetric complications like necessity of the LUCS, and the fetus-related problems like congenital malformations, large for gestational age, birth asphyxia, hyperbilirubinemia, and birth trauma. And long-term problems, there could be very pervasive problems like within a womb, a girl child is being, child being developing within a adverse metabolic profiles where genes can be modified. There could be epigenetic changes, and ultimately that could translate into a transgenerational effect. Now, we know that treatment for the gestational diabetes mellitus or hyperglycemia in pregnancy per se is associated strongly with adverse fetal as well as maternal outcome or adverse pregnancy outcomes. But treatment of early pregnancy associated diabetes mellitus is also not very fruitful in comparison to treatment of standard gestational diabetes mellitus or the classical or late gestational diabetes mellitus, as we can appreciate here. That study is showing that the early gestational diabetes mellitus is associated with more chance of continuation of dysglycemia or development of diabetes mellitus postpartum rather than the conventional or late onset gestational diabetes mellitus. So, overall prevalence of diabetes mellitus or overall prevalence of hyperglycemia in pregnancy is increasing because of the secular trend of diabetes mellitus and background obesity and the increasing age of the mothers. How to screen the early hyperglycemia in pregnancy? We know that guideline is during first antenatal visit, every individual, especially in this part of the world, should have some form of testing in terms of glucose. And I am today is discussing about early pregnancy hyperglycemia, which occurs below 20 weeks of gestation. If oral glucose tolerance test is positive, then we call it early GDM, and if it fits the criteria of over diabetes mellitus, then we call it over diabetes mellitus of pregnancy. Now, unfortunately, there is no consensus guidelines or criteria by which early gestational diabetes mellitus can be defined. We use the same fasting plasma glucose and 2 hour OGTT and HbA1c targets as we used to do with classic or late onset or conventional GDM. Now, we know there is another problem. Across the globe, it has been tried for a long time. We usually follow 2013 WHO criteria, which is based on DPGSG criteria, which was derived from the HAPO study, where fasting blood sugar more than equal to 92, 1 hour plasma glucose more than equal to 180, and 2 hour plasma glucose more than equal to 153 is regarded as having hyperglycemia. And we will look into that one by one. If you consider the fasting plasma glucose more than equal to 92 is considered to be having some form of dysglycemia, but we only should be treating the conditions when the fasting blood sugar is more than equal to 110 but below 125. We will see why. Because if you treat intensively the lower band of hyperglycemia, the pregnancy may leads to a small for gestational age. We may cause more harm. And another problem with fasting plasma glucose is that during natural pregnancy, there is a drop of fasting plasma glucose in first trimester. So often there is a discrepancy between the fasting plasma glucose derived diabetes mellitus status versus OGTT mediated diabetes status at 24 to 28 weeks. Now, as far as HbA1c is concerned, several guidelines including newly published Australian guidelines advocates the uses of HbA1c as the first screening tool. If HbA1c is more than equal to 6.5%, so it's clearly a case of over diabetes mellitus. It has to be treated with insulin plus minus metformin and lifestyle modifications. Now, a cohort study from the New Zealand had shown that if HbA1c at first trimester if more than equal to 5.9%, it clearly indicates high risk of GDM and which is associated with adverse pregnancy outcomes. Our Indian data is showing HbA1c more than 5.5% is associated with increased risk of CGDM or conventional GDM. Now, in that trial, this STRIDE trial, the Indian patients were there along with the Kenyan patients where HbA1c less than 4.9% was associated with no risk of gestational diabetes mellitus, but 5.5% HbA1c was associated with development of GDM. This is the current Australian guidelines, which asks to start with HbA1c. If it is more than 6%, you will ask your patient to undergo OGTT less than 20 weeks of gestation, especially 10 to 14 weeks. Why 10 to 14 weeks of gestation? I will discuss it later. Now we can understand that the glucose metabolism is quite different in the first trimester, in the early part of the pregnancy, which is different. And from the heterogeneity of the data associated with fasting plasma glucose, A1C and 2-hour OGTT, we can understand that. And to have some insight Now we have continuous glucose monitoring. In that particular study, 768 pregnant mothers were put on Dexcom G6 CGM monitor. They are all blinded, and out of them 58 developed GDM. And at the end of the study, they compared the CGM profiles of GDM versus those who not developed GDM. We can see that those who developed GDM, all of them had higher mean blood glucose level. They are having higher blood glucose level, time in range spent more than 120 milligram per deciliter, or the cutoff value of 140 milligram per deciliter higher. The time in range, as my previous speaker was telling, the time in range in pregnancy is quite low. It is between 63 to 120 milligram per deciliter, and that time in range was significantly decreased in patients with gestational diabetes mellitus, early GDM versus no GDM. So CGM can help you to differentiate a patient or understand a patient who is going to develop gestational diabetes mellitus in 24 weeks or 28 weeks. Another study here, it has been showing that in normoglycemic patients, if they are divided by the HbA1c criteria, less than 5% or over 5%, the mean blood glucose in continuous glucose monitoring system was significantly higher, those who are having higher HbA1c. Here is a beautiful example how in classical GDM patient, potential threshold of time in range such as 2.5% above the target, or mean daily blood glucose level 4.8 millimole per liter, can distinguish who will develop gestational diabetes mellitus after 24 weeks of gestation. So these are new markers. We do not know. Even if there are several caveats of all the tests, fasting plasma glucose, OGTT, HbA1c, some of them will fail to predict in early pregnancy who will develop hyperglycemia in pregnancy in 24 to 28 weeks. Number one. Number two, some of them will also overestimate, and it has been shown that 30 to 50% of patients who are associated with some form of dysglycemia defined by any method in the first trimester of pregnancy will become normoglycemic within the 24 to 28 weeks. So there will be always a chance of over treatment. So that's why if you using the CGM data, so there could be some insight that this patient is going to develop probably gestational diabetes or not. There are several biomarkers like urinary metabolites, lipid, protein metabolites are in development in futuristic stock. I'm not going to detail, but I'll definitely discuss a recent publication of TOBO-GM trial, which is the first randomized controlled trial regarding the treatment effect of early onset gestational diabetes mellitus, in which the study participants are from Australia, Austria, Sweden and India. In that trial, all participants are having early gestational diabetes mellitus, meaning having GDM diagnosed before 20 weeks of gestation, and around 50% of them were treated and 50% of them were not treated and treatment was deferred. And there was three primary outcomes. One of them was composite adverse neonatal outcome, and it was significantly decreased. But the other two outcomes, like pregnancy related hypertension and the neonatal lean body mass, was not significantly significantly altered between the two groups. So this is the first study which indicated that treatment of early GDM can provide benefits in terms of neonatal outcomes, though the benefits are mainly derived from the decrease in the neonatal respiratory distress syndrome. If you look into the data very closely, there will be two groups. One group was having a relatively higher blood glucose level, the higher glycemic range, which is corroborating with the hazard ratio of 2 in the original HAPO study. And this group was actually benefited by the treatment. But the patients, the mothers who are actually having a lower, relatively mild form of hypoglycemia, those mothers did not achieve any benefits from the treatment. And actually that lower glycemic range mothers, there was a harm, there was actual harm, there was occurrence of small for gestational age group patients. Another important finding in that study is that those mothers who are diagnosed to have early EGDM below 14 weeks and treated early, those actually get benefited. So two important facets here. Patients with relatively higher hyperglycemia along with early onset, less than 14 weeks of gestational diabetes mellitus should be treated and there would be benefit. As I have stated before, in that study, we can see around 33% of GDM patients become normoglycemic at 20 to 24 weeks. So we need to identify there are some factors which will lead a regression from dysglycemia to normoglycemia in pregnancy, and if we treat them, there could be harm such as development of small for gestational age, and including pointers are those who are having relatively higher hyperglycemia, for example 120 milligram per deciliter fasting, and having histories like polycystic ovarian syndrome are more likely to get benefited. On the other hand, patients having milder hyperglycemia like a fasting blood glucose of only 95 milligram per deciliter, if we treat them, there could be a possible harm. So some case discussion, I'll put a single case and I'll create 3 different scenario. A 32-year-old female, primary gravida, 9 weeks of gestation, obese, having history of diabetes, family history of diabetes and history of polycystic ovarian syndrome. Should we screen the patient? Of course, 100%. Because of her Asian ethnicity, all patients should be diagnosed, should be screened for diabetes mellitus, and along with that she has other risk factors. Now her test result is 1 hour 0 hour 128 milligram per deciliter, 1 hour 230, 2 hour 198, and HbA1c is 6.7%. Overt diabetes in pregnancy, no confusion is that. So we will treat that case. Same case. Now you find OGTT test 0 hour 105 milligram per deciliter at 1 hour 208, at 2 hour 160 milligram per deciliter, and A1C is 5.9%. So it's early GDM, 9 weeks early GDM. Do we treat it? Yes, of course, we will treat it because there is the evidence of ToboGDM trial. Now the same patients having scenario 3, the 1 hour glucose level is 172 milligram per deciliter, 2 hour level is 142 milligram per deciliter, A1C 5.6. So mild hyperglycemia. Do we treat it? Yes, but not very intensively. Only mild lifestyle modifications is probably safe for this patient, because from the ToboGDM trial we have seen if we treat that patient intensively, that can lead to harm like small for gestational age. So take home messages are, we should intensively treat the overt diabetes cases. We should treat only severe early GDM. We should try to prevent late GDM among high risk individuals. We need to identify the regressors. Two can be the higher level of blood glucose at baseline, another is the history of PCO, and as I have shown, the CGM data can help you to identify which patient is going to be benefited more with the therapy, and less than 14 weeks period is very critical, because before that there is treatment opportunity. You can identify who is over diabetic, you can delay the progression of onset of late onset gestational diabetes mellitus, but by at least promoting lifestyle modifications. And I think the precision medicine, CGM profile and holistic care are the way forward. Thank you.
Thank you, Dr. Kaushik, for excellent presentation where he highlighted and cleared the aspect of when to treat the marginally high early gestational diabetes mellitus, and of course the importance of glucose monitoring in deciding the treatment, the intensity of the treatment. The session is open for the discussion.
Yes, in one slide I was showing some lipid metabolites and urinary lipid metabolites and protein metabolites are in pipelines, but they are at infancy. Cannot comment on that right now, but CGM marker can be considered as a novel biomarker.
Thank you. Thank you.